The topic of discussion for today's lecture is the peptic ulcer disease. We'll be talking about peptic ulcer disease, and how we are going to deal with it is we'll be learning all these things, right? And after learning about all these things, we will have correlation with our the content given in Robbins, right? We'll be dealing with all these things. Okay, now let us begin the discussion, right? Now getting into the discussion, the first thing that we should know is the word ulcer, right? The word ulcer means what? The damage to mucosal lining or breach in mucosa, or we can say what? Damage to mucosal lining. So the word ulcer, what does word ulcer? Ulcer means, the word ulcer means damage to mucosal lining or the breach into mucosa, right? And what is the peptic ulcer disease? It is due to the complication of chronic gastritis, right? Chronic gastritis will be more clear further. So it is the complication of chronic gastritis. Okay, talking about its common site, the common site are duodenum, and not all the four part of duodenum, but just first part of duodenum. If you remember, duodenum, it is what? It is C-shaped, like this structure. This is first part, this is second part, this is third part, and this is fourth part, right? The first part is more common, right? Okay, the first part of duodenum. And similarly the antrum, right? Antrum, which is closer to lesser curvature. And another one is our GEJ. What is our GEJ? Our GEJ is gastroesophageal junction, right? Gastroesophageal junction. You can see right here what I was saying is, what is this? This is our gastroesophageal junction. Why is this gastroesophageal junction? Because the upper one portion is our esophagus, right? And the below one portion is our what? Gastrum, or our stomach, right? Okay, so this portion is our gastroesophageal junction. Similarly, and what we said is, we said the antrum, right? The near to lesser curvature. What is this? This is our lesser curvature, and this is our antrum region, and this is also the main prime site of our peptic ulcer disease. And similarly, and we said the first part of our duodenum, right? This is our the first part of our duodenum, right? Similarly, antrum near to lesser curvature, and another the junction between stomach and esophagus, right? Okay, these are the primary site of our peptic ulcer disease. Now what is this peptic ulcer disease? Okay, now talking about the cause, right? Okay, we have two type of forces in our intestine. One is defensive force. Now what is this defensive force doing? This defensive force is protecting stomach from injurious stimuli, right? There are several injurious stimuli that may cause harm to our stomach, right? Okay, what these defensive forces are doing, they are protecting stomach from injuries, right? And another is our injurious stimuli. And these, what are these injurious stimuli? These are trying to cause harm to our stomach. So what are the defensive force that will help our stomach to get protected, right? And what are the defensive force? Talking about the defensive force, the first thing is surface mucus secretion, right? Our stomach, right? What is this? This is our stomach. The stomach consists of what? Our stomach consists of mucosal secretion, right? Surface mucosal secretion. Now these surface mucosal secretion, why are these secreted? These are secreted to protect our stomach, right? Okay, now another thing is bicarbonate secretion into mucosa. Okay, as I said, there are mucus on the surface, right? And these mucus contains what? These mucus contains bicarbonate, right? And these bicarbonate are in fact the real agent that will provide defense to our stomach. Similarly, mucosal blood flow, right? Blood that is flowing in mucosa. Similarly, the apical surface of membrane transport. Okay, membrane transport are also taking part. Epithelial regenerative capacity, right? Epithelial regenerative capacity, right? The epithelium, right? The epithelium present on our stomach. What is the epithelium? Simple columnar epithelium. And the regenerative capacity of these epithelium are also playing role. Similarly, the elaboration of prostaglandin. What are prostaglandin? Prostaglandin are enhancing the production of mucus, right? Prostaglandin are enhancing the production of mucus. So these are, what are these things? These are the defensive forces, right? These are protecting stomach from injurious, right? Injurious. Okay, now what are the injurious stimuli, right? The injurious stimuli are the infections, right? H. pylori, NSAIDs, aspirin, cigarette, alcohol, gastric hyperacidity, duodenal gastric reflux. Now what are these things doing? These things are trying to, right? These are trying to cause injury to our stomach, right? These are trying to cause injury to our stomach. Okay, now so these injurious stimuli are counter-attacked by our defensive force. That is why the favorable environment is being maintained in our stomach. If there will be high injurious stimuli, right, what will happen? these will cause what? This will cause injury to our stomach, and that will lead to what? Damage to mucosal lining, and that is what we are saying, what? Ulcer, right? Peptic ulcer disease. Okay, now why the name peptic, right? Why the name peptic? Okay, we'll come into that thing also. So as I mentioned, that defensive force, imbalance between defensive force and injurious stimuli will cause peptic ulcer disease, and I mentioned these things also, right? Which of the following are defensive force? As you can see, the bicarbonate secretion into mucus, right? This bicarbonate, it is what? It is alkaline in nature, right? Alkaline in nature. As you can see right here, gastric hyperacidity. What is this? Acidity, right? Here this acidity is due to HCl. This HCl is counterbalanced by our what? Defensive force, our bicarbonate. So the favorable environment is going on. If there will be the high secretion of acid, then obviously this bicarbonate is less amount of bicarbonate will not be able to what? It will be not able to counteract our high amount of acid, and there will be the what? Breach in mucosal lining, or damage to mucosal lining, and that will result into what? Ulcer, peptic ulcer disease. Now okay, as I've said that, what are the common site of our peptic ulcer? The common site are first part of duodenum, right? Antrum near to lesser curvature, and I said what? I said gastric esophageal junction, right? These are the common site. And talking about another thing, there is also another thing. The peptic ulcer disease will also result, right? It will also result because of Meckel's diverticulum, right? That contains ectopic gastric mucosa. What I said is Meckel's diverticulum that will contain what? Ectopic gastric gastric mucosa, we can say, right? This is also one of the region or the site where there will be peptic ulcer disease. Now as I mentioned earlier that there will be what? One duodenum and another antrum. As you know, the antrum is a part of what? Antrum is a part of our stomach, and duodenum is a part of our small intestine. So there are two sites, right? Primary two sites in which peptic ulcer disease may occur. Now talking about our duodenal ulcer and gastric ulcer, as name suggests, right? As you have already mentioned, duodenal ulcer, where it will be present? It will be present on the first part of duodenum, and specifically it will be found on anterior wall of first part of duodenum. And talking about the gastric ulcer, it will be found in what region? It will be found in antrum, right? As I said, antrum, which is close to what? Okay, as I was saying, the gastric ulcer, it is present on the antrum region, which is close to our lesser curvature, right? As you can see right here, body and antrum junction, right? Body and antrum junction. Okay, now moving further, the causative agent of duodenal ulcer. How duodenal ulcer occurs? It occurs because of H. pylori, right? H. pylori, the main what? The main causative agent that is associated with duodenal ulcer is H. pylori. And talking about gastric ulcer, H. pylori is also the cause, right? Similarly, NSAIDs. As I mentioned earlier, what is NSAID doing? NSAID is causing a reduction in prostaglandin. Now, and as I mentioned earlier, what is the role of prostaglandin? Role of prostaglandin is to increase what? Mucus secretion, right? Mucus secretion. Now, if there will be NSAID, right, there will be less prostaglandin, and if there will be less prostaglandin, then there will be less mucus secretion. And as we mentioned, what is mucus doing? Mucus is defending, right, our stomach from being attacked by injurious stimuli. So what we can say is one of the cause of our gastric ulcer is NSAIDs also. Similarly, smoking is also the causative agent for gastric ulcer. Now moving further, what we have is duodenal ulcer. It is right. Duodenal ulcer is how it occurs is it occurs by what? Acid hypersecretion, right? Acid hypersecretion. Okay, as acid will be more secreted, as we have mentioned that acid is our what? Injurious stimuli, right? Okay, similarly, now talking about right here, there will be normal acid production in the case of gastric ulcer, right? There is normal production of acid in the case of gastric ulcer. Then what is causing problem right here is there is abnormal mucosal sensitivity. Okay, now there where the problem comes. Okay, as we said, there is normal level of acid. That means the hypersecretion of acid is not going on right here. It is normal. So what is the problem? What is the main problem right now? The main problem is the mucosa, right? The mucosa that is covering the gastric or the antrum of gastric has become more sensitive, right? It has become more sensitive, and what will happen is there will be what, the destruction of mucosal lining in our what, our antrum region. Okay, now talking about clinical manifestation, what I'm saying is, talking about clinical manifestation, there will be epigastric pain, right? Epigastric region in the pain in epigastric region, right? There will be epigastric pain, right? And this epigastric pain is, what will happen is, with intake of food, right? With food intake, it will be reduced. Okay, right? With intake of food, it will be reduced. Why it will be reduced? Because of intake of food, right? It will be reduced because what will happen is, when we will take food, right? We're talking about duodenal ulcer, right? When we'll take food, right? When we'll take food, what will happen is, this food will enter in our duodenum, right? And it will go through several processes, and it will eventually reach into what? Duodenum, right? It will reach into duodenum, first part of duodenum. And what will happen is, as it will reach duodenum, right? As it will reach duodenum, in the region of our this intestine, there will be the increase in alkaline secretion. Okay, what I'm saying is, alkaline secretion will be increased, right? Alkaline secretion will be increased. As I've already mentioned, if there will be alkaline condition, right, this alkaline condition falls under our what? Defensive force. This alkaline condition will neutralize our excess acid, and because of neutralization, what will happen is, after we take food, there will be reduction in epigastric pain. Okay, what I said till now is, there will be epigastric pain, but epigastric pain will be reduced with intake of food. But why? Because as we'll take food, it will reach duodenum, and at the region of duodenum, there will be increase in what? There will be increase in alkaline secretion. As there will be increase in alkaline secretion, what will do is, this alkaline secretion will cause neutralization with excess acid that was causing epigastric pain, right? As there will be neutralization, there will be no more acid to cause ulcer, and it will be, the pain will be relieved, right? Okay, as we have said that the pain will be relieved with intake of food, what will happen is, a lot of people will people will try to take a lot of food, because as they will take food, there will be less epigastric pain. Eventually, on taking a lot of food, what will happen is, there will be slight increase in body weight. That's all, right? Okay, now, okay, we talked about the clinical manifestation in the case of duodenal ulcer. Now, what about gastric ulcer? Talking about gastric ulcer, what we have is, there is epigastric pain, right? Epigastric pain in the case of duodenal ulcer, we say that it will be reduced with food intake. But in the case of gastric ulcer, this epigastric pain will be increased with food intake. But why it will be increased with food intake is that, here we're talking about gastric ulcer, the thing that is happening in antrum, and antrum is in stomach, right? And stomach is the site of HCl production. Okay, what I said right now is, as the person will take food, right, it will go into stomach. As it will go into stomach, there will be what? High HCl production. And here the ulcer is taking place in what? Stomach. And in stomach, we are increasing what? We are increasing the thing that is causing our what? Injury, right? We are increasing injurious stimuli here, and as this injurious stimuli HCl will be more, there will be increase in pain. So we are saying there will be increase in pain with food intake. Okay, what I said till now is, if we will take food, what will happen? This food will go into stomach. As it will go into stomach, what will happen is, this stomach, right? In stomach, because of food ingestion, there will be high HCl production, and we mentioned HCl, right? Hyperacidity as what? As our injurious stimuli. And as there will be high number of injurious stimuli, obviously there will be pain, right? That's all. Now, as we said that, as we mentioned earlier, right, here in the case of duodenal ulcer, the pain was reduced on food intake, but here the pain is increasing on the case of food intake, so people are not likely to have a lot of food, so there will be slightly decrease in weight loss. That's all. Now, another thing that we need to mention right here is, right, in clinical manifestation, right, here on looking toward the biopsy of patient, right, biopsy biopsy of patient, what will be found in biopsy of patient is there will be Brunner's gland hypertrophy, right? Brunner's gland will be hypertrophed, right? Why the Brunner glands? Because Brunner gland, it is found in duodenum, right? It is what it is doing is it is secreting alkaline secretion. It will be hypertrophed. There will be hypertrophy of Brunner gland because it will just need to work so hard to neutralize this excess acid. Okay, and another thing that we need to know is, another thing that we need to know here is, here the Brunner gland, what there will be no hypertrophy of Brunner gland. Okay, now this is what we studied till now, right? Okay, now moving further, okay, I would like to take you toward this diagram. Okay, here as we are mentioning about ulcer, right? We are mentioning about two ulcer. One is our duodenal ulcer and another is our gastric ulcer, right? Now how is the appearance of ulcer, zone of ulcer? Now talking, and when we look toward the zone of ulcer, what we'll see is, we'll see necrosis, right? We'll see the region of necrosis, as you can see right here, right? This was a normal mucosal lining, but because of ulcer, what is going on is there is breach right now, right? There is breach. You can see in mucosal lining there is breach, you can see right here, right? Okay, damage in mucosal lining. Now what is going on is, in this region, what we'll find is, we'll find necrosis, right? We'll find necrosis, as you can see, we'll find necrosis. Similarly, we'll find different inflammatory cells, right? Different inflammatory cells, you can see right here, different inflammatory cells. Similarly, there will be granulation tissues, right? There will be a lot of granulation tissues, and there will be, the body will try to heal it, and in the process of healing, right, there will be the production of large amount of fibrosis also. So this is how the zone of ulcer will look like. There will be necrosis, inflammatory cells, right, granulation tissues, and fibrosis. Okay, now as we are talking about different type of peptic ulcer, one is gastric peptic ulcer and another is duodenal peptic ulcer, right? Okay, now talking about stomach or gastric ulcer, it is less common than duodenum. Okay, and we already talked the stomach. In stomach, the ulcer mainly take place in antron region near lesser curvature, right? And this is particularly near incisure annularis, right? And in duodenal ulcer, we say that it is mainly present in D1 region. Okay, the stomach ulcer is poorly prognosed. There is poor prognosis of our stomach ulcer, and its complication mainly involves perforation. We will just explain it later on. Right now, and there is no night pain in this case, right? Since why there is no night pain? Because in night we are not having any food, and if we are not having any food, there will be no HCl production, no high LCl production. But here the night, here there will be the night pain, right? And there will be the night pain, but night pain will be relieved by food intake, as I have already explained earlier. Okay, and here the bleeding is more common. This thing also will just explain it later. So this was brief. Okay, now we are moving toward the complication, right? Complication, and this complication, we are talking on the topic of duodenal ulcer and gastric ulcer. Talking about the complication, right? The first thing is our bleeding. Now this bleeding is the most common complication in ulcer, right? This is the most common complication in ulcer, right? Okay, and because of this bleeding, what will happen is, okay, now in this topic, the thing that I would like to mention right here is, okay, if you just if you will just look toward the anatomy of our the first part of duodenum, what you will see is, on the posterior part there is our gastroduodenal artery, right? Gastroduodenal artery. Now what will happen is, as there is gastroduodenal artery in posterior region, from this gastroduodenal artery, what will happen is, because of ulcer right here, right, the blood will enter in this region, right? Okay, and that is what the bleeding is. And because of this bleeding, right, what will happen is, there will be melena in the case of duodenal ulcer. But why there will be melena? What is melena? Black tarry stool is our melena, right? And it is because of blood presenting in our stool. Now why is this happening? It is happening because of the bleeding from gastroduodenal artery, which is present posteriorly. That's all. Now here the same thing here also, the most common complication is our bleeding, but here there will be hematimasis. Now what is this hematimasis? The hematimasis is simply a vomiting of blood, right? Vomiting of blood. What will happen here is we are talking about what is going on is we're talking about antrum region right now, right here, right? We're talking about gastric ulcer. Now here what will happen is because of what? Because of bleeding, or here the bleeding, the blood that will come here in this region is from our left gastric artery. Okay, you can see right here it is from our left gastric artery. Okay, now because of the blood entering from left gastric artery, there will be blood in our antrum region, and this will be what? This will be carried out of our body in the form of vomiting, and this is what we are saying hematimasis, right? Okay, we talked about two conditions, right? We talked about the condition of gastric ulcer in which bleeding is the main our most common complication. Here also our bleeding is the most common complication. Here what is going on is the bleeding, the blood is coming from gastroduodenal artery, but here in the case of gastric ulcer it is coming from left gastric artery. Similarly here the melena, right? Melena happens. What is melena? Tarry stool, right? Black tarry stool. And here the hematimasis will happen. And what is this hematimasis? It is vomiting of blood. That's all. Now talking about the malignancy, right? Our duodenal ulcer is always benign. It is always benign. And talking about gastric ulcer, it is benign and also can be malignant, right? This is what it is. Now talking about another main complication is, right, talking about another complication, what we have is, okay, let me see. Okay, talking about another complication is perforation, right? Perforation. Now what is this perforation? Perforation, simply what? Perforation means hole, right? Okay, now perforation mainly, right, perforation mainly takes place in what? Anterior wall, anterior wall, right? Okay, as there will be perforation in anterior wall, right? And we know what is this? This is our stomach, and this is the first part of duodenum, second, third, fourth, right? Okay, as we know there is pancreas in this region. What is here? Here we have pancreas, right? This is our pancreas. Okay, pancreas open into second part of duodenum, right? Second part of duodenum. Now what is going on here is, as there will be perforation, right, because of excessive ulceration, as there will be perforation, right, which is mainly on anterior wall, right? Anterior wall, right? As there will be perforation in anterior wall, what will happen is the excess acid, right here, the excess acid will be leaked into our pancreas, right? The excess acid which was causing perforation in this area, right, in duodenum, right, in duodenum, now it will be leaked into pancreas. That it will be leaked into pancreas, what will happen is there will be inflammation in pancreas, and that will cause pancreatitis, right? Pancreatitis. Okay, not only pancreas, but it will also be leaked into other areas like in peritoneum, and it will cause peritonitis. So perforation, right, because of excessive acid, what will happen? This perforation will finally cause the leakage of acid into pancreas, and that will cause pancreatitis. And also it will cause what? Leakage of acid into peritoneum, and it will cause peritonitis. And because of this pancreatitis and peritonitis, what will happen is the pancreas will totally be unfunctionable, and it may be resulting into death of individual also. So it is so poor, it has so poor prognosis, and there is high mortality in this case. Okay, this is one complication. Now moving toward another complication is gastric outlet obstruction. Okay, we're talking about right now is the gastric ulcer. Sorry, we're talking about the thing that we're talking right now is we're talking about gastric outlet obstruction. Now what is this gastric outlet obstruction, right? Okay, when person is what? Okay, let us talk about one condition in which the person is having peptic ulcer. peptic ulcer disease. Now this peptic ulcer disease having the person who is having peptic ulcer disease, what he will do is it will start taking medication, right? Medication. Now as on taking medication, now what will happen is the region in which there was ulcer, it will start healing, right? On the process of healing, what will happen is there will be fibrosis. There will be fibrosis. Okay, now there will be fibrosis. Okay, now let us see one condition. Okay, right? Okay. Okay, let me draw. What is this? This is our stomach, right? Okay. This is our stomach. Okay, now what is going on is there was ulcer right here. What is this ulcer? This ulcer is our duodenal ulcer, and as there is ulcer, what will happen is as there is ulcer, the person start taking medication and this ulcer starts healing, right? And on the process of healing, there will be there will be deposition of fibrosis fibers, right here. Now if that same person is again attacked with our peptic ulcer disease, then what will happen is again on further medication there will be again another layer of deposition of fiber. Because of this thing, right, there will be narrowing of lumen and that will cause obstruction, right? So it is called gastric outlet obstruction. Here the word gastric, right, it is misnomer, or we can say that since here it is here it is the mentioning of gastric, but in fact it is what it is. It does not take place in stomach, it takes place in duodenum, right? It takes place in duodenum, right? It's just the name is just gastric, but it takes place in duodenum, right? Okay, now where it takes place actually in the region of D1, right? First part of duodenum. Okay, now at this process what will happen is there will be a repeated episode of vomiting. Now why there will be repeated episode of vomiting? Because as we said, there will be obstruction, right? There will be obstruction right here, as the gastric as the food will not be passed properly through this region. What will happen is they will return, right? They will return and they will come out of the body as vomit. Okay, now because of this outcoming of gastric content, right, what will happen is there will be less HCl in body, because as HCl it is produced in stomach region and stomach region's content is being thrown out of the body in the as vomit. So there will be less HCl production, and as there will be less HCl production, right, it will result into less chloride ion. Now what is this? This is hypochloremia, right? Now since there is less HCl, we can say that it is the condition of metabolic alkalosis, right? Less HCl, less acid means more alkaline condition, so metabolic alkalosis. Now in another case, as in vomiting, we are throwing a lot of fluid out of the body, so there will be less fluid inside our body, and because of less fluid inside our body, there will be intravascular dehydration, right? And this dehydration will activate our RAS system, right? Okay, and these will cause retention of water and sodium. Okay, now on this process what will happen is there will be loss of potassium and H plus ion in urine, and as there will be loss of our these, right, H plus ion in urine, there will be hypokalemia, right? Hypokalemia. Okay, and as there is loss of H plus ion in urine, there is condition of aciduria. So here one amazing thing is going on. What is going on is in this part we said that here there will be metabolic alkalosis, but here we are saying that there is aciduria, right? Okay, now at the time of metabolic alkalosis, right, at the time of metabolic alkalosis, in order to counterbalance this alkaline condition, what we do is normally we try to conserve acid, right? We try to conserve acid, but here what is going on is the acid is being lost in urine, right here. So this condition or this ironical finding is called paradoxical finding. It is called paradoxical finding. Why it is called paradoxical finding or ironical finding? Because here what is going on is metabolic alkalosis is going on, right? Metabolic alkalosis, right? And here this alkalosis condition, what we need to do is we normally increase HCl, right? We try to store HCl, but what is going on is we are excreting HCl, right? Acid urea, we are throwing acid out of the body, which is so ironical, right? It is not going as per the plan, so it is called paradoxical finding or our ironical finding. Okay, now in a nutshell, right, there is what? There is decrease in chlorine ion, so hypochloremia, right? There is hypokalemia, right here. Okay, we have metabolic alkalosis right here, and we have paradoxical acid urea, right? Paradoxical acid urea. Okay, now we talked about different complication. We mentioned about bleeding, we mentioned about malignancy, we mentioned about gastric outlet obstruction, we mentioned about perforation. Now let us see about what? Let us see everything briefly. Okay, now what we said, bleeding. What is bleeding? Bleeding is, what is bleeding? It is complication, or we can say it is the most common complication of peptic ulcer disease. And what about perforation, right? It is the what is this? This is the most common, right? Most common complication that will what? That will cause increase in mortality, right? That will cause increase in death. What about what about our gastric, right, outlet obstruction? Talking about gastric outlet obstruction, what it will cause is, it will cause hypochloremia, hypokalemia, metabolic alkalosis with acid urea. What is this acid urea? It is paradoxical acid urea. Similarly, malignancy, talking about malignancy, it will be only associated with gastric ulcer, not in the case of duodenal ulcer. Okay, now how to diagnose it, right? How to diagnosis. Now talking about this diagnosis, the thing that we do is we do urea breath test, right? Okay, urea breath test. It is important to know that one of the main causative agent of peptic ulcer disease is our H. pylori, right? As you mentioned earlier, H. pylori is one of the main causative agent. Okay, in the case of urea breath test, what we'll do is we will mix a radioactive urea with water, right? With water, and we'll tell the person to what? We'll tell the person to drink it, and we will just analyze it through breath analyzer. Now, at the time of what? Expiration, if we detect CO2, that is radioactive CO2, then there will be what? There will be the confirmation of peptic ulcer disease. Now how it is going on? Okay, H. pylori, what H. pylori will do is, H. pylori will produce ureas. Now what this ureas does is, this ureas will do is, it will break what? Radio labeled urea to CO2. It will break urea, radioactive urea, right, which we are giving right here, into CO2, and this C will contain what? Radioactive what? Our carbon, right? Okay, urea and CO2. So if there wouldn't be H. pylori, then there wouldn't be our ureas, and if there wouldn't be ureas, there wouldn't be what? There wouldn't be what? Our breaking of urea into CO2, and we would not expel the radioactive CO2. So that is how the urea breath test works. Now moving further, what we have is, we have definitive test. Now what is the definitive test is, we have endoscopy and biopsy, which is confirmatory test. Now talking right here, we have what? We have two type of ulcer. The one is benign ulcer, right, and another is malignant ulcer. As I have mentioned earlier, malignant ulcer, it is found in gastric ulcer, but benign ulcer, it is only found in the case of what? Duodenal ulcer. Now how to know our benign ulcer and malignant ulcer? Benign ulcer, right, these are small, less than 4 centimeter, but malignant are bigger one, right? These are small, right, flat, right, with regular folds, flat with regular folds, right, and it have clean base. Clean base means there is no necrosis, right, no necrosis or no hemorrhage. But here in the case, we have what we have is, we have big, irregular, right, irregular and prominent margin, right? Okay, and okay, now talking about the place, it is the benign ulcer is mainly found in lesser curvature area, right? This malignant, it is found in greater curvature area mainly. Now there is one another test that we need to know, and that is CLO test. Now what is this CLO test? It is Campylobacter like organism test. Now in under Campylobacter, what we have is we have H. pylori also. Now what is going on here is, what we have is we have taken one test tube, as you can see right here. This is our test tube. In this test tube, what we are doing is we are adding phenol red, right? Phenol red. Along with this phenol red, we are adding urea, right? Okay. Now what is going on here is, right, the gastric biopsed tissue, right? Gastric biopsed tissue, okay, the tissue that we need to examine, right? That is, right, that is kept into our this test tube. Now after keeping it into test tube, if that gastric tissue contain what, H. pylori, or if that gastric tissue is facing problem from peptic ulcer disease, then what will happen is that H. pylori, right, that H. pylori, right, which is present in that biopsy tissue, it will, what it will do is it will break urea. How it will break urea? With the action of urease, right? Urease. Now why we are talking about urea? Because we have said earlier that here what we are adding? We are adding urea and phenol red, right? As this H. pylori will produce urease and it will break urea, right? It will break urea, and on the breakdown of urea, what will come is there will be NH3 release, right? As this NH3 will react with phenol red, what will happen? There will be discoloration of phenol red, right? There will be discoloration of phenol red, and this discoloration of phenol red is our what? Positive test. That's all, right? Okay. Simply what we said, we took what? One test tube. In that test tube we added urea and phenol red, right? And what we are doing is the biopsed tissue, right, biopsed gastric tissue, we are just placing it right here. If it contains H. pylori, what will happen is it will produce ureas, and these ureas will just break this urea into NH3, and as that NH3 will react with phenol red, there will be what? There will be discoloration. That's all. And this is the positive test, okay, right? Indicator phenol red, and discoloration, if there will be discoloration, this test will be positive. That's all. Now talking about the treatment, as treatment, what we provide is we provide proton pump inhibitor, right? Proton pump inhibitor that will reduce gastric acid secretion. And along with proton pump inhibitor, okay, there is one special treatment, that is triple drug therapy. Now what is this triple? That means 3 drugs needed, right? What are these 3 drugs? The one is our proton pump inhibitor and 2 are our antibiotic, right? With the help of these 3 things, right, there will be the treatment of our what is this? This is our peptic ulcer disease, right? Okay, we finished our discussion right here. Now what about other thing? Talking about other thing, okay, we talked about all these things. Now let us move toward our book, right? Robbins. Now what is mentioned in Robbins? Now here, as you can see in these first line, right, peptic ulcer disease refer to chronic mucosal ulceration affecting duodenum or stomach, and is almost always associated with H. pylori, NSAIDs or cigarette smoking. Simply here it is the mentioning of definition. Similarly here, if you see this paragraph, there will be what? There will be the mentioning of site and what? Another causative agents. Here you can see epidemiology. Here you can see what is the causative agent, right? You can see right here H. pylori, NSAIDs, right? You can see aspirin, okay, mucosal blood flow, oxygenation, healing, okay, these are what? Epidemiology, right? You can see the risk factor, we have already mentioned. What are the causative agent? H. pylori, cigarette use, right? NSAIDs, okay, another Zollinger-Ellison syndrome, it is what? The PUD of stomach, duodenum and jejunum, right? It is the complex case. Okay, this is so important. Okay, this I'm talking about the pathogenesis. We have already said. What we have said there are 2 things. One is the defense mechanism, right? Another is what? Damaging factor. We have already mentioned about these things. Now moving further, what we have is we have morphology. Under morphology here, in the earlier, what we have is it is explaining about duodenum ulcer. Later on it is talking about gastric peptic ulcer, as we have already mentioned in description, right? In difference, we have already talked about in difference. As and these are the diagram that is showing what, mucosal what disruption. Okay. And talking about the clinical feature, as we have already said about pain, epigastric pain, how and how they will get relief and why they are getting relief, right? Here it is the mentioning of treatment, right? Here it is writing proton pump inhibitor, right? And the thing that are increasing, right? Increasing peptic ulcer disease must be what? They must be withdrawn. Okay. Now this was all about what? This was all about peptic ulcer disease. With it, there is the end of discussion.